Hi guys, it's Professor Costa and I'm back with Advanced Oxygenation and Perfusion, Adult Code Part 2. Alright, so here is a sample code sheet from the American Heart Association. So you can tell why I don't like to fill this sheet out. I can't tell you how many versions there are circulating. Every facility has their own sheet. They're not required to use the American Heart Association sheet. There are some places that strictly just take whatever the form is that gets published every 5 years and they take that form. It's just not a great way to record something in real time. That's why a lot of folks will take out a scrap paper or even a paper towel. Just be careful not to ruin it. And then they will transcribe that onto this form. So you'll see the time. And then you just check off the boxes, or if you've delivered a medication, you put in the dose and so forth. The time and date that the event was recognized, where was it witnessed, their age, weight, height. Did you call a code blue a hospital-wide one? Yes. And roughly what was going on with this. Was it medical, cardiac, was it a newborn, obstetric, so forth. And did you have a pulseless patient or a pulse with poor perfusion? Sometimes we will do compressions on folks that just, they're agonal. So you have maybe the faintest pulse. And in infants, for instance, you're not learning this, but I'm just pointing this out, why it's on the form, that, with an infant, we would still do compressions if those if the pulse was less than 60. So did they require, there's a lot of stuff on this form. So, and then you'll notice under the patient label section, it'll say, when did we end it and what happened? Did we have ROSC, return of spontaneous circulation? Were the efforts terminated? Was there medical futility, advanced directives, or restrictions by family? Okay. The next slide just shows a picture of the YouTube video that I normally show in class. I did post that separately. So what I'd like you to do is, if I know not everybody has a printer, but if you have a scrap paper and a pencil, what I'd like you to do is watch the video and then see if you can be the recorder. Mark it off in real time. It's pretty hard to do. And so I'd like you to take a little practice and see if you're able to do that on your own. There's a picture. So there is a YouTube video posted just for recording practice. So take out a code sheet or scrap paper and then use the time from the corner of the movie. All right, and see what you can do. All right, so this is the BLS. I literally stole this right off their site. So this is American Heart Association Basic Life Support. This isn't any different than the BLS that you've been taking and renewing, hopefully, during your nursing program at CCRI. So we're going to verify the scene safety. Is this a safe place to perform CPR? Are we in a burning building? Or, we want to make sure that we're not going to also become a victim. We would verify the victim is unresponsive. So we're going to shout for help, 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 or whip out your cell phone and tell Siri to call 911. We're going to activate the emergency response system via a mobile device if appropriate, right? And if we're in a place that has potentially have an AED, you would send somebody to go get the AED. Did you know that at CCRI they have them near the elevators? I don't know if you did know that or not. So we're going to look for no breathing or only gasping, and then we want to check for a pulse. And we're doing this simultaneously. We want to try to do this within 10 seconds, okay? If we have normal breathing and a pulse, we're just going to stay with the person until emergency responders arrive. And that's included in the hospital. So people, want to run off and get things and help their patient. If you have an unresponsive patient that still has a pulse and is still breathing, you're going to call for help. You're not going to leave the patient alone, because if you're unresponsive, you're not going to be protecting your airway. They can quickly go to a situation where they're going to need resuscitative efforts and compressions. So you're not going to leave the room. You're going to call for help and have help come to you. If you have no normal breathing and they have a pulse, that's where we would do rescue breathing. So If we have a Ambu bag, which is a brand name, which is also a bag valve mask, we're going to deliver 1 breath every 5 to 6 seconds, or about 10 to 12 breaths per minute. We're going to activate emergency response if you haven't already done so, okay? But ideally, you're going to call for help before. And you're going to continue rescue breathing and checking for a pulse about every 2 minutes. If you don't have a pulse, then you go straight to CPR and you start your compressions, okay? Hopefully by the time you start CPR, you have activated your emergency response system and you have sent off for an AED, and hopefully it's come back really quickly, okay? So you're going to begin cycles of 30 compressions and 2 breaths. And the second that the AED becomes available, you're going to use it. So don't be like, okay, 1 and 2 and 3 and 4 and 5, and finish your 30th compression. As soon as the AED pops into the situation, it is the star of the show. Because we know that the sooner we're able to shock a shockable rhythm, the more likely we are to bring the patient back. Okay, so 30 to 2, and that's with a regular, bag valve mask. I was going to say mouth to mouth, and there are some situations where you may choose personally to do mouth to mouth. If I found my grandma down, I would absolutely do mouth to mouth on grandma. But, you know, some homeless person at Kennedy Plaza, you know, I would do the compressions, but I would not do mouth to mouth. So if you have the equipment, you're going to do those 30 to 2. If you do not have a safe way to deliver rescue breaths, you would just do compressions until help arrives, okay? But we have all the equipment, we're in a hospital, so we have our bag valve mask and we're gonna deliver those 2 breaths. So the AED arrives, and the very first thing that you do with an AED, everybody should know this, put a little star next to it or write a note, is the first thing you do with an AED is turn it on. Not all of them are made the same, and so if you know, it may tell you to do something different. So it's now a boss. So it's going to tell you what to do. You're going to put the pads on as it tells you to do, and you're going to listen to its instructions. This is BLS. So we're assuming that we're not in a scenario where we have an advanced provider and we don't have the equipment to monitor what the rhythm actually is. So in absence of a code team and a physician and a cardiac monitor, if all we have is an AED, then that's the boss, right? So in a BLS scenario, we listen to the AED. When we go over ACLS algorithm later on, we'll see that the provider and the team is going to be making choices, not the machine. But here we don't have that luxury, we just have an AED. And the machine's going to say if it's a shockable rhythm or not. And there are only 2 rhythms that are shockable, VFib and VTach. That's it. So if it's shockable, it will instruct you to deliver the shock. And then immediately following the shock, we just go right back in like the Energizer Bunny. So we shock and then we continue CPR, right? We're not going to wait around and see if the shock works and check for a pulse. Because every time we interrupt compression, we're losing brain. So we're going to deliver the shock and then immediately resume CPR for 2 minutes, right? And then the AED is going to let us know again that it's time to do a rhythm check and a check for a pulse. We're going to continue until ALS providers take over, ACLS, or the victim starts to move. So, you know, if a patient's waking up, they're going to show signs of spontaneous circulation. They're going to flutter their eyes or move or cough. So if you get those signs, that would be appropriate to stop compressions and check for a pulse at that point. Otherwise, we shock, continue CPR. We're not going to, you know, futz around and check and see if there's a pulse or not. We want to save their brain. If it's not shockable, we're going to resume CPR immediately for about 2 minutes until prompted by the AED. And we're going to continue that. So if it's not shockable, we go right back into CPR and we continue until a 2-minute check. All right, that's BLS, and you all have certification in this. You are expected to know it. So the first step to using an AED is turning it on, okay? If you don't turn it on, it's not going to do anything. You'll see that these nice hands-free pads also have pictures on them. We all panic in a code. No matter how many you've been in, your adrenaline starts pumping and you forget, your first name. So there's little pictures, so exactly where to put it. So rescue breathing. So if our patient has a pulse and the only thing that we need to do until we get additional folks on scene is we would use a bag valve mask, right? So let's say it's an opiate overdose and our patient still has a pulse, but has a poor respiratory effort, no respiratory effort, or a very low respiratory effort. So let's say they are only breathing at 3 breaths per minute. Obviously, that's going to impair an adult patient. So in the hospital, we would use a bag valve mask. So Ambubag is a brand name. So for testing purposes and on your NCLEX, you need to know what a bag valve mask is. So this can be connected to oxygen for FiO2 greater than 21%. Remember, room air, especially in Rhode Island at sea level, is 21%. So you don't have to connect this to oxygen. It's better if you do. So you would just put the connector to the wall. And these rescue breaths should be delivered 1 breath every 5 to 6 seconds or 10 to 12 breaths per minute. If you do the math, it makes sense, okay? So for an inpatient, we have defibrillators, and this is a Zoll. This is what you're going to find on the units at Rhode Island Hospital and at a lot of other facilities in the state. What's nice with these is that they also use, at Rhode Island, they use the same brand of AED. And so if a patient has been resuscitated using an AED, when they, the team, the whole code team arrives, they can actually connect the AED pads to this machine. So they're one size fits all. Not every hospital's AEDs are compatible with the defibrillators, so you'll have to verify that with your facility. So unlike an AED, hospital defibrillators are manually operated and follow a few steps depending on the model. Okay. I also want to point out that there are multiple models of AED/defibrillators, or a combo deal, so that the nurses that can start defibrillating the patient using the AED mode prior to the rest of the team showing up. So if you have a mixed unit where not everyone is an ACLS provider or a certified nurse, and you have a patient that's coding, they can still deliver a shock early using the AED mode on the defibrillator and then simply switch over to the defibrillator mode when the rest of the team shows up. But in any case, if you're actually manually selecting the joules, you're going to select the energy level. So the Zolls are nice as they have a 1, 2, 3, and it goes closest to the knob itself. So there's a pacer function, there's a monitor function, and there's a defibrillator function. And the defibrillator one is in red. So you're going to point the knob to 1, and then it says energy select. You're going to pump it up to whatever the provider tells you. And for, depends on why we're delivering for cardioverting, or if we're defibrillating a patient that is in an actual code blue, the provider will tell you the number of joules. So, at 150 to 200 joules, depending on the situation, or they may just say max joules. I've been in codes where they just say, just deliver max joules, and you just hit the up button until you get the maximum amount available on the defibrillator. Usually 200 for a biphasic and 360 for a monophasic. Charge the device. So there's a little button that says charge. And then it'll tell you, it'll beep and say that it's ready, and then you're going to hit the shock button. All right. So most of these can also cardiovert and pace, and the Zoll model that's on this screen also does function as an AED. So virtually all hospitals nowadays have hands-free devices. They love to have the ones with the telephone cord on them, the little squiggly nanocord on TV, because it makes for a better, the doctor's face is hovering over the patient with the pads, and we stick the pads on your chest and then we stand away because we don't want to get zapped. But most hospitals have hands-free devices. So just to show you the internal paddles, those are for defibrillation internally during open heart surgery. So if a heart stops during, when they have the chest open, they don't need, we're not going to put stickers on the inside of your chest wall. They're going to use these sterile internal paddles. So clear. So here's a picture of someone. You can see how hard it is with the non-hands-free, the ones with the wires attached, how hard it would be to deliver the shock, look at the monitor, and not touch the patient. We absolutely do not want to be anywhere in contact, physical contact with the patient while we deliver the shock. And the reason for that is electricity travels and it wants to get to the ground, and sometimes you're the fastest way. So if you're touching the bed in any way, shape, or form, you are going to get electrically shocked. And we don't want that. So no touchy, no touch. All right. And so if you're delivering the shock, if you're the person running the defibrillator, it is your job to say, I'm clear, you're clear, we're all clear, shock delivered. So you would tell everyone around you, you're delivering the shock, that you've delivered the shock, and not to come near the bed. If you just pop those pads on and deliver a shock and electrocute a coworker, you could end up with a second code victim. So this is the Adult Cardiac Arrest Algorithm 2015 update. So this is just BLS, all right? And then we've added the ACLS algorithms with the protocol. So I just wanted you to see this before we start talking about it. So we're going to take BLS and then we're going to run with it. So we're going to do BLS survey, no pulse. We're going to activate emergency response, call for help, ask for an AED or defibrillator. We're going to start doing high quality CPR. If we have oxygen available, we're going to do that. If we have the defibrillator or a monitor or an AED, we're going to start that. And then we're going to check the rhythm. If it's shockable, remember, as soon as we identify a shockable rhythm, and there are only two, VFib and pulseless VTach, the minute or second we have the ability to deliver electricity to that heart, we're going to deliver electricity. So as soon as that machine shows up, we are going to take care of it. If you look on the right in the boxes, you'll see all the CPR quality. Push hard, at least 2 inches, and fast, 100 to 120 compressions per minute, and allow for complete chest recoil, right? Minimize interruptions and compressions. Interrupting compressions, we're losing brain. Remember that. Avoid excessive ventilation. So we want to do those one breath every 5 to 6 seconds, okay? If we're doing rescue breathing. Or if we're just doing BLS, we want to just follow the 30 to 2, all right? And we don't want to hyperventilate our client, okay? Rotate compressor every 2 minutes or sooner if fatigued. So if that person is showing that they're not doing the compression as well because they're tired, we're going to switch them out, all right? So if we do not have an advanced airway, we're following the 30 to 2 compression ventilation ratio. If we have an advanced airway, we can initiate quantitative waveform capnography. I think you might remember that from your oxygenation lecture, where we can actually check to see how much expired CO2 is coming out with each breath. So if we have expired CO2 in sufficient amounts, that means not only is good ventilation occurring, but also good perfusion. So that means we have gas exchange. So that's a really good indicator that we're doing high quality CPR. So if we're doing waveform capnography and we have a very low end tidal CO2 level, meaning no good gas exchange is occurring, we're going to try and improve our CPR. All right. If we have an arterial line, we can check for intra-arterial pressure, and we can see if we have inadequate pressure, okay? So we're going to keep going around this circle. So we're going to, if we have a shockable rhythm, we're going to shock it. And then we're going to continue CPR, around and round every 2 minutes. And then we're going to start our drug therapy. These drugs are not new to you. They are exactly what you got in Nursing 1063, pharmacology. All right, so we're going to try and establish IV or IO access. all right? And then we're going to give epinephrine every 3 to 5 minutes. And the dose that we give is epinephrine 1 milligram every 3 to 5 minutes, all right? So, and then if we have a shockable rhythm, there's only two. So if we have a shockable rhythm, we have VFib or pulseless VTach, then we would administer amiodarone. The first dose is 300 milligrams and the second dose is 150 milligrams, okay? And that's it, all right? So in a basic ACLS cardiac arrest, we're just gonna go around and around. If it's shockable, VFib, pulseless VTach, we will shock. We're gonna continue CPR. We're gonna give our dose of epinephrine. If we've identified that it's a shockable rhythm, we would give amiodarone, and then we may just stick with epinephrine over and over and over, okay? If something else occurs, if the patient converts to another rhythm, we may switch algorithms. So if they become, if they have return of spontaneous circulation, but are still hypotensive and now are bradycardic, we would then convert to the bradycardia algorithm. But right now we have no pulse, so we're going to follow this around and around and around and around. All right. So drug therapy that you need to know would be the epinephrine dose, 1 milligram every 3 to 5 minutes, and amiodarone. The first dose is 300 milligrams and the second dose is 150. If it's decided that an advanced airway needs to be placed, once the ET tube is placed, then we would ideally use waveform capnography, though not every facility has that capability, but we would change how we deliver compressions and breaths. So we would switch from 30 to 2. We would switch to continuous chest compressions with no interruptions, and then through the advanced airway would deliver 1 breath every 6 seconds, which becomes 10 breaths per minute. All right, so we don't have to count as we do compressions when we have an advanced airway because we're going to do continuous chest compressions. So if we have ROSC, which is return of spontaneous circulation, we're going to do a full assessment, pulse and blood pressure. We may see ROSC before we see movement because the end-tidal CO2 in a waveform capnography, it returns to normal level. It may go up, so it would go above 40 millimeters of mercury, right? So we may see it through our monitoring equipment before we see patient movement. And signs also include spontaneous arterial pressure waves with intra-arterial monitoring. So if you have an arterial line, you may suddenly see a waveform where you didn't have one. So the H's and T's are at the bottom here, and we call them H's and T's. Reversible causes of cardiac arrest. Is it hypovolemia? Are they, really, really low fluid volume, or are they bleeding? Hypoxia. Are they in an acidosis? That's what the hydrogen ion's for. Do they have hypo or hyperkalemia or hyperthermia? Hypothermia, I'm sorry. And the T's would be things like attention pneumothorax, cardiac tamponade, toxins, a pulmonary thrombosis, PE, or a coronary thrombosis, which would be acute coronary syndrome, right? So is there anything that we can figure this out?